on working together. My name is Arthur van Zanten. I'm internist and intensivist and head of the ICU in Ede, the Netherlands, and also a professor at Wageningen University. And my co-chair is Vincent Liu from California, working for Kaiser Permanente, and we're happy to chair this session on working together. So it's all about teamwork, of course, in the ICU, and we're really excited that we have such a great faculty for you this afternoon to discuss these important topics. Can we improve the outcomes for our patients by working optimally together? And I hand over to my co-chair to introduce the first speaker.
Thank you very much. Let's welcome to the stage Dr. Axel Nierhaus from Hamburg, who will be speaking on optimal organization.
Thank you and good afternoon. And I was given this title. I wasn't sure what you would expect. And I think I spare you the diagrams, the flowcharts, and communication psychology. I just tell my story, I think, because I think it's a remarkable story of how ICU system evolved in my university hospital in Hamburg. COI statement, irrelevant for this talk, I think. And let's start with a case study, the case study of a big northern university medical center in Germany with 1,400 beds. And at the time, we had like 9 ICUs scattered all over the place, over the campus. There was an anesthesiology ICU, whatever that is, neurosurgical ICU, neurology, internal medicine, maxillofacial surgery, cardiology, cardiothoracic surgery, etc., etc. And this looked like this on the campus. Somewhere else, everywhere was a little ICU shop, so to say, and you could spend hours walking over the campus and trying to find the ICU you were supposed to be at. So this is there was a stage before, so to say, and there were many islands. There were strict barriers, borders even, and the communication atmosphere wasn't very collaborative. It was sometimes antagonistic. Well, that's how we were trained, actually. So we had a lot of siloed operations. We had heterogeneous SOPs all over the place, communication barriers, competition, antagonism. We had inefficient staff allocation. We had inefficient resource allocation, as you can imagine by this. And we all had a feeling of profound disorientation and chaos. And then things changed, because in 2008, the Department of Intensive Care Medicine was founded. And from then on, all the ICUs found themselves in one building under one roof, as you see there. And the world changed in such a way that we had now, well, we hadn't Disney World, we had ICU World. A continent, not many island, but now a continent with all the ICUs side by side. And I think this was a very important step our board of directors has decided. Of course, there was a lot of resistance, as you can imagine, a lot of resistance and a lot of discussions and my beds, my power, my money, etc. But in the end, it worked out. Now, the enemies are not within, but they surround us. Now, we are ICU. That was a definite culture change. We have shared SOPs. Communication has significantly enhanced between the wards. The shifts are synchronized, which is important. You arrive at the same time of the day and you leave at the same time, roughly at the same time of the day. We have a unified patient data management system, electronic health record. Wherever you go, you see the same layout, the same kind of data handling, etc. And that gives you a very good feeling about the whole department. We have common educational goals, specialization and training, no longer any insular specialization as we used to have before. And of course, staff allocation in this situation is much easier, as well as resource utilization. We can also have different devices, no more different devices. We have the same ventilator, very advanced ventilator for all the beds. We have the same renal replacement machines, etc. And this adds to a definite increase in the technical quality of care, we think. This is, of course, open to discussion later. Now, this in practice, this is the floor plan of all the ICUs in one PDMS. You see here the oversight, so to say. We have 142 ICU beds, adults, of course. We don't do pediatrics for obvious reasons, but this is a large department. And we call it KIM in German, Clinic for Intensive Care Medicine. And of course, we don't mix everything up. It's not a huge bowl of everything, but we have retained ICUs, medical ICUs, neurological ICUs, neurosurgical ICUs, cardiological ICU, etc. We don't want to have a chaotic mix, but we do want a specialization within the unit. Each unit has 12 beds. That's the current state, and of course there are other sources of patients who refer patients to us, like the emergency room, PACU, recovery, acute care, stroke unit, bone marrow transplantation unit, coronary care unit. We exchange patients on a day-to-day basis with these step-down units and monitor units. And also, we are in a network within northern Germany in a kind of hub and spoke model, because we do a lot of telemedicine, serving community hospitals all over northern Germany. So this again is a source of demand and patients for us, apart from the internal requests we have. Now, who does this? And it's every day we have a colleague, dispatcher, who is an experienced intensivist who gets all the information, all the demands, all the requests from in and outside the hospital, and he or she talks to the head of the nursing staff permanently, and also to the telemedicine specialist who channels, so to say, the external demands. This means, this organizational structure clearly means that at the bedside we have a clear multi-professional approach. And you see them all. Maybe I've left some out, but they are very important. The respiratory therapist, the intensivist, the clinical pharmacist you will hear about in a minute, I think, physiotherapy, ICU nurses, speech therapists, cardiologists, surgeons, etc. They all work together. The ICU doesn't belong to them anymore, but the patient does. So we work in a very interdisciplinary and multidisciplinary round every day, which is, I must personally say, a lot of fun, and much more fun than before. When it comes to keeping, and this will be also a talk this afternoon, I think, keeping the staff, this paper recently showed that leadership, adequate staffing, and material resources and collegial nurse-physician relationships promote better outcomes for patients, because what we want to avoid, of course, is exhaustion, emotional exhaustion and burnout, and colleagues leaving the unit for reasons that are mostly grounded by communication problems and emotional problems. So I think it's a very important way to assure that these key points in professionalism are respected every day. In conclusion, of course, Critical care settings are complex, they are demanding and dynamic, I don't have to tell you that. And interdisciplinary collaboration, quality control, and integration of best practices are key everywhere, not on 1 or 2 or 3 ICUs, but on all the ICUs, at least in my model. We share the goals as professionals of high quality of care, efficiency, and staff satisfaction, which is very important, I think, and it achieves this decidedly multidisciplinary approach. And as I've shown you, organizational consolidation may be promising for the departments and ICUs of the future. Thank you very much.
We have time for questions.
Maybe, I don't see any questions. Maybe I can ask you a question. Maybe you can tell us a little bit about, did you see improvement in patient care also by this reorganizational plans and what were the main barriers? You showed that there were some islands and problems, but what was the top 3 maybe of the problems you had to address to get one organization?
Yeah, thank you for the question. Very important, I think. The top problem, and maybe it's a typically German problem in German healthcare, was, giving up beds, giving up staff, and giving up power, because in Germany, medicine still is very hierarchic, and that was a big problem. But since this was a top-down decision, the hierarchy wasn't an issue. And unfortunately, because it was a board of directors decision, we don't have any before-after data. This project, unfortunately, wasn't a scientific project. It was just done, you know. But anyway, I think it's the number of patients we were able to treat with this expansion and this way of organizing ICU in a big university hospital has been rising year after year, and currently we have 8,800 patients per year in all these ICUs. So that is, of course, not a quality indicator, but the readmission rate is around 1.4%.
And do you have like subsystems? Because you said everything is general now, but you still have some areas where you have more cardiac surgery patients or more trauma patients.
Yes, we have retained the specialized ICU. So there is a clear defined cardiothoracic ICU. There's also a neurological ICU as a neurosurgical ICU. So some of these specific ICUs have not been dissolved in an amorphous mass. We still have specifications. But there are many interdisciplinary ICUs, and I tell you what, the people, the staff, both the doctors and the nurses, they all like to work on these interdisciplinary ICUs very much.
Question?
Thank you for the topic. What do you do when in neuro ICU you have 2 free beds and you need 2 other beds in cardio ICU?
This is this I experience every other day. That's not a problem for 2 reasons. The standards and the technology and the electronic healthcare system is the same everywhere. So the reallocation of a given patient who comes in and is not specifically admitted to his or her area of interest, may neurology or neurosurgery or cardiothoracic, the admission of the patient to the ICU is the first thing that's most important, and the reallocation happens 24 or 36 hours later. So yes, we redirect the patients, but the first thing is first, they need ICU, and this can be done anywhere on this kind of campus. So since the foundation of this model, we had to less and less patients we had to deny admission. That's the flexibility which is really important, I think.
Okay, thank you very much, Dr. Nierhaus. Thank you. We move on to the next speaker. That's Nicole Hunfeld, a pharmacist from Erasmus Medical Center in Rotterdam, the Netherlands, and she will discuss the important role of the pharmacist.
Yes, good afternoon, everybody. I would like to tell you how I started in 2008. At that time, I was a resident, and my supervisors from the pharmacy had a question for me. Could you go to the ICU, and could you define the best moment of the day for us to do our interventions? Because they went daily to the multidisciplinary meetings, but discussions about drugs was not that common, and there was no time, and people were rushing in and out. So they said, this doesn't feel okay. Can you make sure that we will get the best moment together with the medical staff? And that was basically the question. So I had no clue where to start. So I asked the head of department at that time, like, okay, can I be in the ICU for, let's say, 2 weeks? Can I just see and check what you are doing? And then he said, oh, that's okay. You can start within 2 weeks and just, we always start Monday morning at 8, make sure you're there. So I was there and I followed them during the week. And I think after 2 weeks, I had quite a complete vision of what happened there, what they did during daytime, and how busy it was. And then I decided to do interventions from medical reviews, pharmacological point of view, and I measured those during 3 months. And in the end, I was able to show both the medical staff, but also the staff from the pharmacy, like, okay, if you check every patient, you do a review in a standardized way, you can easily get a lot of interventions. And then we discussed, when do the intensivists want these interventions to be discussed? And then we said this multidisciplinary meeting is not the right time point of the day. It's busy there, it's too busy. An hour before, when the nurses come in and when they discuss their patients, might be a better meeting to do this. So they changed this routine, and I checked recently, it's still there after all those years. So that's, I think, a good sign. Then I moved, because my internship finished, I moved to Erasmus Medical Center, and I really loved the ICU, I still do. And then I asked the supervisor there, or the head of department, okay, can I do something in the ICU? And then they said, no, of course not. It's academic ICU. They don't like pharmacists. I don't think you're welcome there. So I thought, okay. And then I thought, let's give it a try. So I did the same thing, made an appointment with the head of department, and I just said, if I come in with 2 colleagues, because it's 30 beds there, it's way more than in The Hague, where I did my training. If we come with 3 colleagues and we will measure for 3 months, is that okay? And then he said, what's your final goal? I said, well, my final goal is that I want to become an ICU pharmacist. Yeah, that doesn't exist in the Netherlands. I said, I know, but then I will be the first. And then he said, oh, that sounds like a good plan. Go ahead. So we measured again, 3 months. We had a lot of interventions again, same setting or same way of research, but different hospital. Then we made a business case with these data. And I was able to show, or I basically sold myself to the ICU and saying, if you hire me for 0.5 FTE, I will do that many interventions that will gain money. And then he said, okay, deal. It was quite easy. I never expected to be that easy. But he said, I have 3 things that need to be done. You need a desk in our ICU staff office. I want you to be there. You need to be visible. You need to be there as well. You need your own ICU pharmacist phone, so people can reach you anytime during the day. And you need to be a member of the medical team, otherwise you will be alone there. So I was really part of the team from that time. So this all happened. And then I needed training, of course. I had these 2 weeks and I knew what was going on in Erasmus Medical Center, but I think it's always good to do something else. So after this 2 weeks training I had as an intern, I also got training in New York and Boston from hospital pharmacists there. It's normal, they are there 24/7, so they really showed me what they do. I followed the ACCP prep course for hospital or ICU pharmacist, and I really learned myself to ask questions all the time. If I don't understand, I always ask the intensivist, and they always like it. They always answer me, and I think we get good discussions then. And I think also what really helped is I got married to an intensivist years ago, so if I don't understand it, I can always ask it at home. With the data from these two hospitals, we made a nice publication showing that even if it's a teaching hospital or a university hospital, pharmacists can really help during patients' round. This has a clinical impact, it's a benefit, but also a financial impact, which is positive for the ICU, of course. So we had these interventions from two hospitals, we combined those, we scored them again, so we made sure that we had two pharmacies scoring the interventions. We also noted we had the proportion of accepted interventions, so we checked those and compared those between the two hospitals, and we were able to calculate the cost-benefit ratio. The results then in the teaching hospital, we had 160 patients with 332 interventions. In the university hospital, this was all in 3 months. We had 174 patients with 280 interventions. The acceptance rate was 67% versus 62%. And the cost-benefit ratio was €190 per accepted intervention in the teaching hospital and €136 per accepted intervention in the university hospital. Then I started in the ICU in Rotterdam, and then I had to define my daily tasks. So I started with rounding every day. We have 4 wards, so I was able to do 1 ward each morning. I managed the stock management because I think that was way behind and this needed really an update. And I also started analyzing the costs of all the drugs in the ICU. So we made quarterly lists of changes within cost, etc. And then we start changing those as well. I'm involved still in all protocols with medication in there. Also, I have my own medication protocols and therapeutic drug monitoring protocols for the ICU. If there's a quality project, I can check the protocol adherence, and we always discuss this with the staff. I do a lot of teaching and research, and I got my own training. Then over the years, this changed a bit. Because of all this rounding, I can predict what happens with certain patients. So some patients don't need my attention, and I know which patients do need my attention. So I switched it a bit, but I'm always visible on the ward. In the meantime, we fully integrated HICS, our computer system. So I was able to train pharmacy technicians to do the first checks of the medication. And if they have a question, they know where to find me. We started our research line called Pharma ICU. I'm still involved in a lot of teaching, and I'm responsible for the medication cost and also for medication safety. And I started the whole green ICU movement, which is great fun. And I thought, okay, I can tell you what I do, but I think it's better if I show you what I do or what happens, then you have better vision. So I made a small movie for you.
I will give you...
Oh, then it goes back. See if it works.
I will give you a quick
You
look
helping me there?
at our intensive care unit. This
Yeah,
is
it's
one of
moving,
the
but there's no
standard
sound, I
rooms.
think.
They are all made in the same setup. And now we are walking towards the pharmacy. We have a special system in place. The pharmacy prepares almost everything for the nurses. So we have a pharmacy in the ward, like this. With a special hood, so the technicians can prepare all the medication, so it's ready to administer for the nursing staff. It's all coupled to our computer system.
Okay, then it stops. Okay. Otherwise, I'll just skip it and I will tell that we coupled the whole system. So if the doctor prescribes an order, the pharmacy gets the order, they print some kind of protocol, and then they start preparing from the protocol. It's all with barcode scanning, so it's quite a safe system. We use this for all the preparations that need to be done on a patient's name. Besides this name preparation, we do have a top 15 in the stock with ready-to-use syringes. So there are sterilized syringes. So we also decided that with these sterilized syringes, you have certain advantages. They are there in the ward. You can keep them for 2 years. They don't need to be in a refrigerator. And because the content is sterilized, we told the nurses now that we changed the protocol and they can use them for 7 days. So they don't have to switch the syringe every 24 hours. So we made huge progress there. What we also did is we really discussed together with the nursing team, like, okay, which syringes do you need? What takes a lot of time? Which ones do you use most? Of course, I knew it, but I wanted them to have the lead in this discussion. So this has been in place for, I think, 3 or 4 years now, and we are really happy with it. And it also gives the pharmacy time to prepare the other ones. And those are the ones that take a lot of time or are difficult or certain concentrations, but it's all protocolized together with the emergency department and the OR. So we made sure that all these concentrations are always the same, so we can never mix up syringes or content. This took me years, and I think with the previous speaker, if there's islands and power going on, yes. But I think we stayed calm and we discussed this many times, and in the end, everybody said, okay, this works and it's fine and it's safe. I think there are more pharmacists in the group. We are now trying to make an Isicem ICU pharmacist group, so we know where to find each other, and I think we all want to share knowledge, because there's no specific training for us. So there will be the first training in Brussels this year, so people that are interested, please apply, because we need you there, and we have a special WhatsApp group, and we can share knowledge within this group. Feel free to contact me if you want to join. And one other thing that I think I skipped is that we are really lucky. I cannot go back anymore, I think. No. That we had a publication, this one in ICM last month. So we were really able to show what our role used to be in the pharmacy outside the ICU. We were literally picking up the phone and replying to questions. And with this whole shift towards the ICU, we are there. And I think we have a way better feeling of what happens there. And I think also our interventions are much better than they used to be. And I think also, and I think this has been proven by a lot of American pharmacists, the outcome is much better if you have pharmacists in your ICU. We were also able to show this in the latest publication, which came out last week. There's a whole item about the ICU pharmacist. And what we try to do in this specific paper is we compared what happens in Europe. And there's a huge difference between the countries still, but I think it sets a nice position of where we are, and we also know where we would like to go. So we have a lot of work to do together, but I think we'll get there, and we at least made a start. And to summarize, working together from an ICU pharmacist perspective is that you can be the liaison between the intensivist and the nurses. I do this every day and I still like it, and it's always nice to be there and to join the discussion. The pharmacist is always there during daytime, so if the medical team switches after a week, we are the continuous factor. Sometimes I know things from a patient that the new team doesn't know, so I can really help there. I know the ICU drill, I know when to step in, and I also know when I have to wait, when it's busy there. So we have a lot of respect towards each other. And I think pharmacists are good at changing a process and systems. That's how we are trained. So this can really help in the ICU if you want to change something. And I still enjoy working together with the whole team every day, which is great fun. And then to finish, if there are pharmacists in the room, we have a special meeting tomorrow, so feel free to join. It's during lunch, and I hope to see you there. Thank you.
Thank you very much, Nicole, for this excellent presentation. The paper is open for discussion. Any questions? Well, the microphone will come to you.
I'm just curious. What it might be a stupid question, but what do you mean by an intervention? What this term means? Could you give us a practical example of an intervention?
Yes, an intervention can be that a patient has a certain dose of antibiotic. There's a change in kidney function. I notice it before the intensivist sees it, and I ask them, okay, can we change the dose? Then it's scored as one intervention. Double medication, like 2 laxatives or 2 opioids, or also all those, really from a medication perspective.
An additional question. So you noted that there was very good satisfaction with this type of collaboration. Is there one area where there's persistent antagonism or, like you noted there was also some challenges. Is there a type of medication or protocol that is, a source of persistent conflict?
Yes, of course. That's a nice question. I think that I often hear that if there's a debate about the protocol, then the intensivist can always say, yeah, but this is a special patient, so I don't follow the protocol. And then in the beginning, I didn't know what to say. Then I thought, oh, they might be right. But after a couple of years, you know what happens there. And you also know what type of intensivist uses this, because I know them. And I can also see on Monday after the weekend, I can see who was on call during the weekend from the medication chart. I can see it. And they know that I know it. Yeah.
There's one more question in the back.
Yeah, thank you very much, Mark Visoki. Do you have any experience and practice in the NICU and PICU where medications are specifically very challenging, right? I mean, so would it be correct to say that if we don't have that kind of nice resource, I'm talking about ICU pharmacists, would that be or make sense to push the administrations to have at least something in the NICU and in the PICU? Does that make sense?
Yes, we copied this model to the PICU and the NICU. And I think for them it might even be more important because the volumes are really small, the concentration changes all the time, and we do specific checks there to tackle these problems. And it takes more time.
Thank you very much, Nicole. Wonderful entrepreneurial work. Thank you. So it's my pleasure to introduce our next speaker, Dr. Elie Azoulay from Paris, who will be speaking on the topic of how to retain your staff.
Good afternoon, everyone. Happy to speak after Nicole, and we are going to see whether we can try to retain our staff. I have no disclosure with this presentation, but before we speak, I think that we need to get together and agree. We can disagree and we can be in conflict with each other, but we need to agree on some of the things. Staff retention only intends to keep productive and talented workers and reduce turnover. I think that we are really thinking on different things, but is it a failure to return? Is it a failure to engage our healthcare providers? Is it about competitive issues? I did 3 years in the ICU and now I want to move to surgery. Is it about a mental health issue? And we say always burnout, and we are going to look at that. Or is it about the work-life balance? And all of us believe that the next generation is very much engaged and focused on their own work-life balance. But they are normal, and we are not. So we just need to think differently. So who, what, where is the problem? I think that the main issue in that is that we are asking to someone to solve the problem that he has created. And intentionally, I said he. The model one is I want to retain my staff, so I want to lock them in my ICU. My ICU is a jail. And it happens. You can live in a city or in some countries where there is no alternative choice. If you are an ICU nurse or an ICU doctor, you cannot work elsewhere than in the ICU where you work. The second one is I'm a manipulative department chair, and I really want to make my people really follow my engagement. 3, I've been trained, I learned, I'm a team builder. And otherwise, I can be considered to be the mother or the father of my staff, and then the problem relies there. So there are different situations according to where we work and different outcomes. You don't want to, and you are right, if you want to avoid an epidemic of burnout in your ICU, you may want to have a staff with more cohesion, and we can understand why. You want to reduce burnout, we can understand why, we are going to speak about it. It's about the brand. You have a philosophy that makes that you are really thinking differently on your IC, on your job, and this is a branding issue with yourself that has a sense. You want to have a continuity because we know that if we are having nurse or doctor shortage from one day to the other, it's going to be different people, family and patients are going to be very unhappy, and this is what we call the fragmented care that should be an outcome per se. But there are many different outcomes. Recently, we published a paper on the different ways, and you will look at the literature, and there is many papers on staff retention. This one was maybe more focused on nurses and on ICU. I just remind you that the first paper published in JAMA reporting nurse shortage has 1 century. So older than the oldest people here, so it's not something new, and we need just to recognize that we should tackle this angle a little bit differently. So these are the different things, and of course this is the perfect slide not to be read. The reality is that working in the ICU, and even if I were a clinical pharmacist, I would have the same feeling, because you know you are not spared. You are having exactly the same symptoms than all of us. There are plenty of symptoms that have been reported. Moral distress for nurses, PTSD, perception of inappropriate care, dissatisfaction, anxiety, depression. And you know, sometimes you look at the long-term outcome and you start to see very different things. The conceptual model comes, and I just picked this figure from a medical thesis from a colleague from Auckland. And I think that this is a clear imbalance. You want to leave the place where you work because there is a mismatch between satisfaction, stress, and burnout. If you work in an ICU where you have a huge satisfaction because there is a huge cohesion and there is a clear leadership and people make efforts towards you, so then you would accept a certain level of stress. There's a balance. And then burnout is the perfect result of an imbalance between satisfaction of stress as far as we are dealing with a chronic condition. PTSD has been reported in nurses, and we need to understand, here there are plenty of ICU leaders, and we are not psychiatrists, we are not psychologists. We work with them, we work for them, and they work for us, but we need to understand the words. And I think that we need to make the difference between stress and burnout. Stress is too much. You have too much. You have too much to do. You have 3 lectures, 2 meetings, 1 Zoom fatigue. You have to call the kids to be sure that everything is okay, and it's too much. Burnout, it's almost the same, but the internal feeling is emptiness. So the results is very different. So you would say that, like in immunology, different people, different personalities facing the same burden would result either in stress or in burnout. Maybe, but there is no consensus about that. Burnout is not depression. Depressive symptoms are very different. They are quite easier to characterize. Conflict, conflict means that there are at least 2 people. If you're in conflict with yourself, we need to change the taxonomy and use another word. But conflict is another word that leads also to the same symptoms, and it's very frequent in the ICU. So you should be, and we should be, as ICU specialists, be aware that this is burnout. This is the typical feature of burnout. You're at work and you just want to sleep and you are really exhausted, and when you're at home, you only think on the work. So this is the typical feature that would make, that is an alert that make that you feel overwhelmed. You're unable to meet constant demands, which is the first reason why you are leaving the ICU, because you feel that you are not capable to do your work. You're vulnerable, disillusionized. You're even cynical. You're helpless, hopeless. You're worn out. And you really start to lose motivation because you believe that you need to disengage yourself to help the patients. This is a paper, and Joseph Bienvenu in the US is one of those psychiatrists working in the ICU environment, and there are many, and I must say that he is one of the best. And I think that as clinicians and ICU specialists, we need to recognize the three domains. It's very easy now because there is a tool that measures burnout, and thanks to Christina Maslash, you are able to measure exhaustion, depersonalization, and reduce personal accomplishment. But otherwise, you can yourself understand the different symptoms and the different differential diagnoses. So you would target the idea that your colleague or the team has a number of symptoms of burnout based on that. One of the things that is very important is to take the quotes. So you do a meeting, a unit staff level, and you listen to people, and people, they have no control over the work, and it's monotonous, they are not rewarded, they are not recognized, they live in a chaotic and high pressure environment, etc., etc. So you need to really understand that in your ICU, there is a sense of burnout. This balance between too much stress and too less stress is really something that the occupational doctors are really paying attention to, that because this is really the balance that makes that people stay. If you want to keep the people in your ICU, you also need to balance a certain level of stress, which, by the way, signs is a signature of our job in the ICU, but at the same time, you provide to people recognition, perspectives, and many different things, offering them really a sense of satisfaction. When we go to another understanding of burnout, we need also to understand that burnout is never acute. Burnout is the result of a very long-term chronic process. It's not acute stress, which is something else that we know, it's the chronic stress. And this chronic stress has a lot of events making that we are able to prevent burnout. We know how to try to prevent burnout, but we are also able to prevent the feeling of burnout, because there is the syndrome and the amount of symptoms that are very transient. If some of you have been on night shift 2 days ago, they are very likely to have 2 times more burnout than others. But then after 2-3 days, you're going to recover. But the syndrome is then when it's really something that takes you out of your job and you are leaving the ICU. So initially you have this kind of alert, then you try to resist, and then you're down. So when we look at that, we also need to understand that our role as ICU specialists is to avoid the time where the person left, because stress makes that people are here, but they have this face, making that you are able to recognize the stress, but when burnout is over, the person is not there anymore. So if we go to that, I need to give a real congratulation to 2 people. One who has described burnout as a burning process, and it's Professor Freudenberger, and he has really defined burnout as based on working condition, mismatch with people expectations, and coping. So this is how you can drive a discussion in your department, trying to understand whether you can improve the ways and what is in place to prevent burnout. The second person is Professor Christina Maslash, amazing colleague. You would write her an email, she would respond. And she's, very, very helpful and precious. And she created, validated, and developed the MBI, the Maslash Burnout Inventory, that has the strength to recognize burnout in the 3 different domains. So us, not being psychologists or psychiatrists, we are able to use a tool to characterize the different domains and to think on burnout. There is no proper consensus, but the third domain is very little used to define burnout. Burnout is mostly defined on exhaustion and depersonalization. Of course, you can see that us, ICU specialists, we are at the top of the pyramid. We are very much exposed to burnout. And recently, during the COVID outbreak, we said, wow, 50% burnout. But this is exactly in the same proportion that was reported before. We know that a lot of ICU specialists, a lot of ICU nurses have burnout, maybe a little bit more during the first COVID surges, but now we are back to the normal, which is about 50% of our colleagues. We want to deal with burnout. We want to prevent burnout. So there are the 3R solutions: to recognize burnout, to reverse, and to build resilience. These are 3 different steps where different people should be engaged. To recognize, this is our job as ICU specialists, being leaders or not leaders in our ICUs. I need to know whether, and you need to know whether I am with feelings of burnout. Reverse is a collective, local strategy. But the resilience is something that is based on a common responsibility by policymakers, hospital directors, administrators, of course the ICU leadership, but also every one of us. It's a collective responsibility to decrease the prevalence, the burnout prevalence in our departments. Well, building resilience, there is a huge literature. I'm not entering into that. I just want to say that the pillars are about communication, and there is a trial before-after showing that in the ICU there is a reduction in burnout by improving communication, team cohesion, promoting well-being. And here there are a lot of studies that are ongoing if you go on clinical trials, including sophrology, acupuncture, hypnosis, etc. So more to come, and the psychological support, of course. And I think that this needs to be incorporated in the ICU, but also working with occupational medicine to work on that. There's a call for action that has been published recently, and ourselves, the European Society of Intensive Care Medicine, we went to the European Parliament and we signed with the members of the European Parliament a manifesto making very clear that we are asking that those decision makers, those policy makers, have to recognize their own responsibility on organizing the healthcare system and on setting up plans to recognize and prevent burnout, and to mitigate, of course, the symptoms of burnout. So this is a call for everyone. It's not only us, because then we would be burdened by addressing colleagues' burnout. This is my last slide. And I need to tell you that sometimes leaving the ICU is also an option. And we know there is a turnover. The turnover cannot be zero. We know sometimes that for some people, and in some situations, working in the ICU is not anymore an option. Because the person cannot really cope with the things that are in the ICU, because conflicts are created by almost nothing, and because there are no real options to deal with that. In those cases, I think that it's not a problem to help our colleagues to go to another place where to work. Sometimes it can be another ICU, because the problem is about the local recruitment, if they are working with burn patients, with cancer, with pediatric, with neonates. So we can understand that, and the people would move to another ICU and they would be very happy. Sometimes it's about the ICU, and people need to move to another structure where there is less people dying, less end-of-life decisions, and maybe less stress. And sometimes we need also to teach people how to engage in another profession, and we are very lucky to be able to do many. So not retaining a colleague sometimes and helping the colleague to go to another place is sometimes an option that we need to consider. Thank you.
Thank you very much, Elie, for this overview of your thoughts. And maybe there are questions in the audience. If not, I would... oh, there's one, please. There's another one. Okay.
Yes, thank you for your presentation. I've been working as an intensivist in the Netherlands, in Germany, and now in France. And I always have the same problem. It's not that I'm not understood by the person on the floor, but I'm deeply, I've got a great problem with this understanding of the management. It's usually an idiot with an MBA who sees that we spend a lot of money in the ICU and who tries to reduce that. And that's what would be a reason for me to leave the ICU. And I heard you talking about this problem, but I want to ask you, do you recognize this, and what's your therapy?
Well, I fully recognize, and I really congratulate you for having moved from one place to the other, because you're looking for serenity. So this is the good point with you. You are not crazy at the point that you are staying to really be burdened every day. So this is the good point. Maybe the third place is not the right one, the fourth one will be the right one. But you still need to, yeah, you know, we are all old. Yeah, I think you just need to identify what is in this system, what are in this system the things that take you to be chronically stressed. Is it about the decision-making process? And in that case, there are situations where less decisions can be made. We heard this morning that we had almost 300 decisions per hour. So that can be a problem. Is it end-of-life decision-making, which we can understand? Is it about just the relationship you have with the staff? So then you should go to a private clinic and do your job by yourself. It won't be ICU, but it can be something else. So the good thing is that you open the file to be able to recognize what are the troubles. And very easily, I think with a professional, you can identify what are the things and find the place where you would go. But preventing burnout at a leadership level, it's more to find the smallest common denominator to burnout, to find ways to prevent burnout for the big numbers. This is what we can do at an ICU level. It's very difficult at an ICU level to find individual things, like, for example, your or my personality, that would not fit, would not match with the local system. So this is something that should be dealt by occupational medicine or sometimes the colleagues from psychology and psychiatry. We, as ICU leadership, we need to find ways to prevent burnout for the entire team, and for everything that is specific, we need to be helped and work together and understand. Maybe you would be the one being responsible for preventing burnout in a system. And maybe the problem is not burnout.
Thank you. That's a very good point. Because one brief comment. I was lucky to be able to change hospitals, even countries. But there are nurses, for example, they have much less this opportunity. So I think for us as an intensivist, it's also, I very much agree with you, a responsibility to create an environment where everybody can do his job and be satisfied. Thank you.
I fully agree, but my colleague Julia Wendon is going to let you know how you can be happy, which is, you know, another.
We have one more question.
Dr. Jonk here, please.
Yeah, hello, I'm Job Jonk here from University Hospital of Brussels, visit Brussels, and I'm since short the ICU director there. Do you think there's place for a psychologist to maintain the staff and to maintain the nurses, making everybody work together?
This is a very valid point, because when we say we call for action, having a psychologist dedicated to each ICU is a commitment. And we believe that this is useful for patients, for family members, and for the staff. I must say that I could not imagine my ICU without a psychologist. She, and sometimes it's he, but she is helping us to recognize the situations and to find those individual situations and also to organize things to make what we call the ethical climate, that, by the way, has been very widely described here and worked on by Dominique Benoit in Ghent in Belgium. This ethical climate is a kind of digest of all the management skills that every ICU should apply to prevent this feeling of perception of inappropriate care, moral distress, symptoms of anxiety and of burnout. And I really believe that, yes, the psychologist would help at an individual level, and the leadership people in the ICU, the head nurse, the department chief, etc., would work at a global level.
Maybe I can ask you something about workload. We can measure it. It's very popular, and we have managers, and staffing is money, and the hospital has financial restraints, of course. But the perceived workload is not the same as the actual workload. And sometimes I have the feeling that maybe after COVID, the perceived workload has increased, while the actual workload is not that different as before COVID. Did you also notice this kind of effects, and how do you deal with that?
Yeah, Arthur, there is something in the literature that is not really coherent. When you look at the doctors, you know, for example, that the number of night shifts and the number of patients they had is increasing the symptoms of burnout, but transiently. When you look at the nurses, this doesn't appear because the working hours for nurses are more, I would say, normalized in Europe, and this is the reason why. But when you look at the data in the US, you see, for example, that when you are changing nurse to patient ratio, every additional patient you give to a nurse increases mortality by 16% and burnout by 20 to 30%. So yes, workload, the objective workload, like adding a patient per nurse, decreases safety and increases burnout. The reason why I think that we might have differences between the perceived workload and the objective workload is the feeling of burnout. Yeah. Because you feel that for the same threshold and for the same amount of work, your feeling would be different. And I think that we need to work on that. I think it's just a mismatch. There is not a typical workload that would lead to burnout. There is a perceived workload, as you just mentioned, that would lead to burnout in some people, in certain conditions of vulnerability, etc., etc.
Thank you for that.
Thank you.
I think we have to move on. Thank you very much, Elie. We move on to the next speaker. That's Dr. Julia Wendon from King's College in London, and she's addressing the topic how to keep everybody happy. That will be difficult, Julia.
So I got this title, and I thought, and I don't think I understand what happiness is. But I do know what grumpiness is, and I'm quite often grumpy. But what I think we all do is to try not to express that grumpiness to our colleagues, because when we do express grumpiness, we create conflict and we certainly generate unhappiness. So this is something of a narrative conversation the next 10 minutes. I don't think there's much data in it, and a lot of it is I'm old and I'm looking back on what's made me either happy or unhappy. But I think without question, we all need to know what we're trying to achieve, whether it's at work or outside work. And that sense of what is our purpose when I come through the door of the hospital and of the ITU. It's looking after patients, it's looking after families, and it's working with my colleagues. That's the purpose. The people are paramount. And I've realized when I've talked about this, I've focused mainly about people in the intensive care unit, or very closely related to it, the patients, their families, colleagues. Perhaps what I haven't talked about is the surgeons, the physicians, and the management who sit outside. But I'm going to talk around that as we go. You want to know that you're making a difference, and you need to be able to track that, and you need to be able to look at it over time. And I think you need positivity. Now, that doesn't mean that you've got to be horribly positive every minute of the day. That's unbearable. It really is. But you do need to be positive. And however tired I am or miserable I am, I make a point of bouncing through the doors of the ITU and saying good morning to everyone. And I think that positivity is essential in how we generate and self-generate happiness and respect our colleagues. And that needs to be hello to the cleaner, the porter, the nurses, everybody. And I don't want to feel like a mushroom. Now, this is a particularly British saying, I think, so I apologize. I don't know whether it translates. But you do not wish to be kept in the dark, and you do not want to be uninformed or given rubbish information. And that, for me, is how we interact with colleagues in the ITU and also outside the ITU. We need to be told when the ITU is over budget, when the hospital is over budget. And we need to understand that and be able to work together to solve it. That gives a sense of satisfaction and a sense of engagement and possibly happiness, not necessarily, but positively. So that communication and information gathering and giving is essential to contentment at work, even if not happiness. So, the people, that's the teams we work with, it's the patients we care for, and their families. And ITU is often not happy we have to give really difficult news to people. Sometimes it's the patients we give bad news to. Sometimes it's their families. And we need to deal with that distress, and we need to deal with it compassionately, empathetically, and be able to walk away from it. I remember when I first started in ITU, which is more years than I care to remember, but someone said to me, if giving bad news to someone once or twice a year doesn't mean you have to walk out in tears, it's time to leave the ITU. And if it doesn't impact on you at all, it's time to leave the ITU. And we need to find a balance in between that. And that's really important. So what do I think? It's that diversity of approach that makes people happy. We don't want to all be the same, but we're all pointing in the same direction. As we heard from our pharmacy colleagues and the first presenter, we've got to have shared notes, shared understanding, common knowledge across the team, across the unit, across the critical care department, and across the hospital. The level of data that you'll get will be different, but we need to understand it. We need those shared quality improvement data, the morbidity and the mortality data, the patient experience. Those feedbacks allow you to feel that you're doing something and that you have control over your working environment, and that generates a sense of happiness. And you need these leadership models of engagement. We need to have open ears and open arms for each other. All of us go through bad days. All of us go through more resilient days. That's what makes a good team. And recognizing that change is difficult. I don't want to change, but I have to. I have to change regularly. And sometimes that, to bring up your point, sir, is when the management are saying, we're broke. You really can't have that nice bit of kit that goes ping. Well, sometimes it's working together, sharing that as an ITU team, and saying, how can we make small increments on that spend? And it's the small increments that add up. It gives you a sense of control, and you can feel happy at the end of the day. But what do we also need very much, as we heard from Elie, support and well-being, to be consistent in our approach. If you are seen as a colleague to not be consistent in the manner that you deal with patients, families, and colleagues, you've got a problem. And they'll see it, and it'll make things deeply unhappy. We need succession planning and the future. I love it that my students now teach me, and they tell me I'm talking rubbish. That makes me deeply happy. The world is moving on. So, again, what do I think we need? We need outcome variables that we share for our patients and for our staff. Staff survey data. Do you know how your staff feel as a group? Are they hacked off? Are they happy? What can they do? What have they identified that they want to change? It's doing that that allows you to move together. Also, whether they'd recommend your unit or whether they'd say, oh no, go to that hospital over there. If they're saying that, you need to address it. The patient and family feedback and getting small, coherent teams to work together, cross-react and empower each other. We can't work in teams of 50, we can work in teams of 12 or 16. That number is really important. Management is good, rigidity is, I was going to say pants, which is an English phrase. It's bad. Being rigid is bad. So, this data is really interesting. We need to protect the psychological well-being of staff. Really interesting data beginning to come out here. And organizational well-being. We are good sometimes at individual and team well-being, but we also need to look at organizational well-being and how we promote that sense of team well-being. Empathy and kindness, resilience, planning. We're all in it together, and I'll talk something shortly about Neil Greenberg's work on this. And again, it's that direction. We're all looking for the focus is the patients and our colleagues. And don't medicalize being unhappy. It is reasonable to be unhappy. We all go up and down, and we need to accept that. So this work is actually from Elie, and it's looking at resilience and mental health. And what comes out every time in terms of how we deal with colleagues, how we deal with ourselves, is to provide an environment where we can grow under stress rather than diminish. And we, as team members and as leaders, need to ensure that we provide an optimal environment for that. That is, providing people with experience and supporting them so they don't feel out of their depth. There is nothing worse than feeling you are unsupported and you are out of your depth. You need a team. You can't exist as an island. People are really unhappy if they feel they're being judged. Don't judge people. Recognize that we've all gone there and made mistakes. And they feel personally responsible. And that's not fair either. We need to be a team. And this is work from Neil Greenberg, which I think is relevant to how happy we are at work particularly, but maybe also outside work. Moral injury, omission, commission, and betrayal by a trusted other. I froze and I didn't do anything, so you beat yourself up. You need to be supported by the team at the time. I didn't do the right thing. I tried to do something and it didn't work. Or I felt let down by a supervisor, a colleague, or an organization. We have it in us to prevent that happening. Our relationship with line management is pivotal with regular touch points, savvy conversations. And that can be a savvy conversation with someone who's got their MBA, or it can be with a clinical colleague. It is saying, don't do it that way. Be considerate for the environment. And we need to be ensured that we get really good leadership training in all of this. Health promoting leadership, we can help each other through conversation, and we can say thank you, a meaningful thank you. There's nothing nicer than that at the end of the day. And create a meaningful narrative to what's going on. We're not all in the same boat, but we are all in the same storm. And in that we will have psychological resilience at different time points over the course. So, what do we need? We need teams and individuals. We need to understand what matters to people as individuals. We need to ensure that staff really understand what the job's about. There is nothing worse than a new member of staff arriving and they are terrified because they didn't understand that ITU isn't like in the movies. It really is sometimes challenging. So we need to onboard people safely and well. We need to be able to step away. And we need sometimes these basic requirements that really induce a sense of happiness. Because if I can't put my coat in a locker, I'm pretty miffed with the world. I need a calm space, I need a coffee area, I need lockers, and I need control. Control of rostering, self-rostering. Really powerful. So I really like this work. It's UK-based, it's Civility at Work Saves Lives. And you can see there on the far right what is being uncivil. It's fairly obvious, but we all do it. We talk over people, we belittle people, and it happens every day, all the time. We're a bit sullen, we're a bit shouty, we're a bit aggressive. All of these things, small microaggressions, are uncivilized. And clearly it has an impact. And this Civility at Work program has found that if you really can generate that sense of happiness, we are less stressed and less worried, and we rest better, more productive and happy when they're at work, more engaged with less sick leave, and we spend less on alcohol and chocolate and more on fruit. And this incivility work has carried on in terms of simulation. The slide on the left is from a NICU environment, but it basically showed that rude relatives worsen outcomes. So We as teams need to take that on as individuals. If a family are being difficult, it is very easy to step away and think, really don't want to deal with this today. But actually you need to step forward and say, you're clearly unhappy with your relationship with us, what we're doing for your relative. How can we make this better? Because otherwise your outcomes are going to be worse. Similarly, data in terms of surgical complications has also been shown in terms of rudeness and incivility to increase. And increasingly, rude surgeons impair anaesthetic performance. So being civilized, being kind, improves happiness and improves outcomes. And I really like this paper. You can actually measure happiness. I didn't know that, but it varies over time. It's not surprising, really, but this is a nice little paper and worth looking at. So I think the other thing we must consider, and I am coming to the end, Chairman, my apologies, I'm chatting for too long, is that we need to consider our patients when they leave ITU. And I think that is a sense of their happiness, their contentment we need to consider. It is terrifying to leave an ITU where you have doctors around all the time, you have nurses around all the time, and you are put into a ward environment where the ratio might be 1:4, 1:6, and you rarely see a doctor. And this is really now moving out to call for concern where patients and relatives can activate an outreach service. And we need to provide that feedback to the staff in the ITU also as to the importance of this. Follow-up services similarly feed it back. It improves a sense of happiness. I'm going to skip that and say, this is what it's all about. It's being an optimist. The glass is never half empty because air makes up the rest of the space. So, Chairman, ladies and gentlemen, I'm going to stop at that point.
Thank you.
Maybe I can ask a question, Julia. Many hospitals have this strategic visions and missions, and it's all about patient-centered. So patient and families is number one. But we will have so many patients in the future, in the next decades, and we have probably less staff, because in the Netherlands at least, studying medicine or becoming a nurse is less popular. So should we refocus our mission and strategy a little bit more on the well-being and happiness of our staff? What is your opinion about that?
I couldn't agree more. And I think a strategic vision, clearly everyone wants to be the best hospital with the best outcomes and the best patients, but they also want to provide an environment where staff are supported and developed. And a lot of hospitals now have that in their mission statement, and I think that is really important. And that sense, the hospital I work at has photographs of staff members that says thank you to them along the walls outside the hospital, and that sort of thing, it makes me smile when I come in the morning. And the ward receptionists, similarly, they have photographs of them up. It's good.
Thank you.
Julia, I think both you and Elie alluded to kind of a period of burnout or acute increase and then a release, or kind of a time to go back to homeostasis. I wonder if you observe that, in your unit, because we all face different shocks, whether it's a persistent long one like a COVID with waves, or maybe the loss of a team member or a change in the structure of a hospital. And whether we understand what is the kind of healing period or the return to health, in our staff.
Yes, and we all talk about healthy buildings and unhealthy buildings, but we don't talk really necessarily about how you promote that healthy team, that healthy individual. And I think that period to get back to homeostasis really depends on the intensity of the insult, the background of how you were prior to that insult, and the healing environment or the supportive environment that can be contained following an event. And I think we often focus on a big event, But sometimes, I don't know about all of you in the audience, I find that having multiple chronic patients in the ITU, I find really draining. And I think it's because, as Elie said, ITU is a stress environment. By and large, we've gone into it because we like stress. And therefore, not being stressed can be really quite unpleasant. But back to your point, I think we need to find different environments for different individuals wherever they are on that curve. And I think having that psychologist or a psychosocial input into a unit, not just for patients, but also for staff, just as drop-in, not medicalizing it, is really paramount. And a sensitive feedback to your direct manager, your direct local manager, who can really support you in saying, have a few admin days, take a step back and be empathetic. Let's not do the same every time.
Yep, thank you. Let's keep moving. So it's my pleasure to introduce Dr. Craig Coopersmith from Emory in the US, and he'll be speaking on how to lead successful rounds.
Thank you. I've just learned 2 new things. I've learned, number 1, that I am in fact a mushroom. And number 2, I've learned that I would do way better if I just yielded these 15 minutes to Dr. Wendon, had her talk, and just let me continue sitting down, because she'd do a better job than I would. My disclosures are the same as every other one of the 10,000 talks I'm giving at this meeting, and none of them are relevant to this talk. My other disclosure is every other talk I'm giving at this meeting is going to have a zillion references, and this talk will have 0. I'm going to start with a question. I'm going to ask 2 questions for audience participation, and only 2. Who's the most important person on the team when rounding in the ICU? Shout it out. Okay, so every one of you got that right. And I guarantee if you ask your team when they look in the mirror, a lot of them are going to get it wrong. So the first and most important thing to remember is who's the focus of rounds, and the focus of rounds is, in fact, the patient. Of course, though, if you ask people on the team, what comes to your mind immediately, they'll say the doctor, the nurse, me. It's important to remember that. And then when the patient should be the center of rounds, is the center of rounds, everything should work well, but that doesn't mean, of course, that everything does work well. So what are the keys to successful rounds? Well, let's first talk about who should be on rounds. So who should be on rounds? The doctor should be on rounds, right? And the patient and doctor are a good start to rounds. But clearly, that's not enough, right? So who else should be on rounds? Nurses. These are nurses in one of the ICUs that I work in. So I think this should, I hope, be self-evident to everybody in this room, but in case it's not, the patient spends 100% of the time with themselves. My ICU has I'm in charge of 354 ICU beds, but when I'm clinical, I have 23 beds. And so I might spend 5% of my day with a patient. Depending upon the staffing, and I understand this varies from country to country, there's going to be a nursing staffing of 1 to 1, 1 to 2, or 1 to 3, which means that the nurse is going to spend somewhere between a third to a full portion of their day as opposed to my 5%. On a second-by-second basis, there's no question that the nurse has an infinitely better understanding of what's going on with the patient than I do. Also, the nurse is likely to know the patient as a person and know their family pictures and know their backgrounds. And I'm likely to know what their SCVO2 is and what their lactate is. And they're complementary. So who else should be on rounds? The multi-professional team. So who's on the multi-professional team? Obviously, it depends upon your ICU, it depends upon your structure, it depends upon your culture, it depends upon your country. And I would say there's many options, and the more of them, the better. In the United States, we have APPs, nurse practitioners, physician assistants, pharmacists, respiratory therapists, dietitian, nutrition support, social work, spiritual. Ultimately, the more, the better. And each of them has unique expertise and perspectives that can improve the quality and outcome of your patients. So on a high-functioning team, everybody knows the roles. Everybody performs their roles to the best of their ability. The team trains together, sort of what Julia was talking about, and everybody respects their teammates. It's incredibly important that nobody is more important than anybody else and nobody is less important than anybody else. An ICU can't function at this highest level unless everybody is actually functioning at the same level. And it can't function at the highest level without mutual respect. I'm going to get to that in a minute. So here are some high-functioning teams. I understand that the rest of the world does not actually call this soccer. Really? I understand that when you look at football, and these are the last number of World Cup winners, every one of these is a high-functioning team, right? So what comes in a high-functioning team? So in a high-functioning team, it's critical to recognize that everybody has their own expertise. To use the football analogy, the striker is the best striker, and the striker can't play goalie at all, right? And the goalie is the best goalie, and the goalie can't play midfielder. Everybody has their role. I cannot do a nurse's job. I cannot do a respiratory therapist job. The slide just changed, my God. I'm going to have to, oh, there we are. So I'd like to believe that I'm a good doctor. I know for, wow, what I'm seeing over there has nothing to do with what I'm seeing over here, so I'll just look over here. That's like amazing. Whoa, it's like psychedelic. If you guys can see what I'm seeing over here, it's like totally psychedelic. It's really cool. So the bottom line is we should be the best at what we're doing. But we have one role in the team, and your role is not more important than somebody else's role. Everybody is the best at what they're doing at the same time. The nurse is the best nurse. The pharmacist is the best pharmacist. I hope I'm the best doctor at any given time on rounds. And all of us together make up the team. So I'm going to take that with, what's my name? Anybody? Thank you. That is, in fact, my name. I understand that what I'm going to say might be different between cultures. Okay, so I call our nurses by their first name. I call our pharmacist by her first name. I call our respiratory therapist by their first name. I call every member of the team by their first name. And what does it say to a group of colleagues, all of whom went to school, all of whom are practicing at the highest level of their professions, if I call them by their first name and they call me Dr. Coopersmith? Anybody who calls me Dr. Coopersmith, if I don't know their last name, I will ask what their last name is, and I will refer to them as Mr. So-and-so or Miss So-and-so to make it abundantly clear, and I will call our nurses Miss So-and-so, and a couple of them just can't do it. And they continue to call me Dr. Coopersmith, and they'll say, good morning, Dr. Coopersmith, and I'll say, good morning, Nurse Cross. I will never call somebody by their first name unless they call me by their first name. If we're going to be equal, we're going to be equal, and I get that there's differences in cultures, but there's an intrinsic inequality if you're calling some people by their first name and they're calling you by your last name. So to my team, and she got it exactly right, my name is Craig. So what's the name of my patient? Again, I understand this varies between cultures. So I tell all of my patients Mr. or Miss, and I don't care how old they are. I call a 20-year-old Mr. I never call them by their first name unless I'm specifically told to by the patient. Again, this is a sign of respect. They didn't choose me as a doctor. You choose your outpatient doctor as a doctor. They happen to end up in the ICU. I happen to be the person they got. I didn't know them prior to the ICU admission. I don't know about their family lives or anything. And then if I expect them to call me Dr. Coopersmith, which I actually don't care, but all the patients call me Dr. Coopersmith, and then I refer to them by their first name, again, it's a sign of inequality. Out of a sign of respect, all of my patients are Mr. or Miss or Mrs. So who else should be on rounds? The family. Here's my second question. Show of hands. Who has the family on rounds with them? Who does not have the family on rounds with them? I am most definitely not in the United States right now, because that is sort of surprising to me, actually, because I thought it was going to be the opposite. So that was about 15% did and 85% did not, and I actually thought the numbers would be flipped, honestly. So I'm going to say this. You can be like, wouldn't work in my country, wouldn't work in my society, and it's okay. You can throw things at me. It's cool. We can all agree that the family is scared, the family is tired, and the family is stressed. And this is the worst time of their lives. They have little understanding of what's going on, and they've retained, even if you tell them in incredibly plain English, or French, or Spanish, or Italian, or German, etc., they've retained very, very little of what you say. Making the family part of the team drastically improves the experiences. Now I feel bad that I don't have references, because I would have put up 1 billion references to show that actually this is true. And it may improve family patient care. So first and foremost, Patients, when families join rounds, they are universally thankful. It takes away that mushroom that Julia was talking about. They're not being left in the dark. They hear every single thing that you're saying, even if they don't understand it, and I have to translate it from doctor speak to English afterwards. They hear everything you're saying, and they're incredibly grateful. They'll often tell you something that you don't know about the history, and then they'll often tell you something that you were told that somebody's telling you that is frankly wrong. If you're literally there and the family's saying, no, that didn't happen, oh, no, that didn't happen, you're going to get things that are actually going to benefit their loved ones. They're not going to be in the dark, and it truly makes lives better for them. So, what time should rounds start? Anybody? Yeah. It doesn't matter, as long as it's standardized, right? So some people I've talked to at this meeting start rounds at 7, 8, 8:30, 9, I don't care. But it can't be a different time each day, because that's rude to your team. It has to be in a standardized approach, because a standardized approach is clearly superior. And the flow of information on rounds is critical. The daily plan needs to be understood by everybody. And when you have a daily plan, a flow of information, it can be done really well, it can be done poorly, or it could be done not at all. So what's the worst? The worst is saying nothing, because as smart as you might be, your team is not made up of a bunch of mind readers. If you do not articulate the plan, nobody knows what the plan is. What else is bad? Talking and talking and talking and talking, and I do this, by the way, and talking and talking and talking. At least a couple of them, I see somebody, Charlie's like, oh yeah, you do. And that's actually bad too. So what's actually needed? First, you need a reiteration of the daily plan or order readback. I talk, it doesn't mean it was retained. Somebody has to say it back to me. Just because I said it doesn't mean it was understood. Mandating that somebody repeat it back to me and that orders are read back decreases the risk of errors. What else do you need? You need a to-do list. This can be electronic if you've got the technology. It can be written, but it can't be optional. Everybody in the team needs to know what's supposed to be done at the day. At the end of the day, you check off what has been done and what still needs to be done. So this is our incredibly high-tech ICU. We actually do have the machines that go ping. And on every single room, we have, and we even color code this, blue for day, black for night, red for emergencies never get erased, and green for everything else. So the surgical team wants to write something. And then you check it off during the course of the day. So when you get to afternoon rounds, you know what there is to do, whether it has been done or not. And so the night team knows what there is to do and whether it's been done or not. So what else is needed? You need a checklist. Okay, which of these things up here are exciting? DVT prophylaxis, stress ulcer prophylaxis, antibiotic stop dates, what catheter is in place and for how long, and if physical therapy is seeing the patient. Who here, show of hands, I'm going to ask a third question. Who here gets excited about these questions? One, sweet. We got to talk afterwards. We got to figure out a way to work together. So, which of these potentially decrease morbidity and mortality? Every single one of them, right? So, it's easy to focus on the vent, on pressors, on CRT, on ECMO, on procedures, et cetera. On the acute life-saving things. As Julia just said, we like stress, we like acuity, we like things. Who here is like, oh my God, I totally saw the patient on DVT prophylaxis today. I got it going, right? And because of that, it's easy to forget it, right? And so you forget all the routine portions of the EICU care, even though they save lives. And because it's easy to forget the routine parts, a checklist mandates that you go over them each day so you don't forget anything. So here's our incredibly complex ICU again. Here's our checklist at the bottom to actually go over all of that stuff each day so we can't forget. The very end of rounds is literally DVT prophylaxis is, stress ulcer prophylaxis is, lines are this, and every single tube in line. And you could say no DVT prophylaxis because the platelet count is 25. And you could say the patient has no tubes or catheters in place, but you can't skip it on every single patient every single day. So how long should rounds last for? Not too short, not too long. Rounds that are too short are not acceptable because there's inadequate transfer of information. And if everybody's yawning and everybody is finding a way to walk away, rounds are too long. There's no ideal amount of time to spend per patient or per ICU. It depends on the size. But the goal is for all patients that you have this co-clinic rounds unless there's bedside teaching. So an important point to remember, the patient in the last bed is as important as the patient in the first bed. I have 23 beds. At bed 1, everybody is paying attention. At bed 23, people are looking up things in the computer, also known as shopping online on Amazon, because they think I can't see them, or they're walking away because somebody called them away, which is another way of saying, I'm just going to go away, have some coffee and come back, or they're yawning or they're totally clued out. But that's somebody's mother, father, husband, sister, wife, etc. They're just as important. And so if they're not paying attention, that's a problem. So it's imperative to make sure that either you start at a different place each day, so it's not always you're seeing patient at bed 1 first and bed 23 last, or that everybody gets the same attention, you're finding some way to engage somebody. If you're working in an ICU environment, you're gonna have learners. Here's a billion different types of learners. We have every one of them. I have like this massive posse around me. I don't actually do anything. I stand there and everything just magically happens. But we do teaching on rounds, right? So from the standpoint of teaching on rounds can be educational or a waste of time. They could be terrifying or welcoming. They could be interesting or boring. And we can be a role model, what Julia said, for what we want our trainees to aspire to, or we can be a role model for what we don't want our trainees. Every one of you grew up and said, I want to be like them. And every one of you grew up saying, I don't want to be like them. They're both role models, but you prefer to be the former role model. So there's many ways to make rounds horrible. Being condescending, I'm better. Yelling at people, the incivility, I like that term. Talking again and talking and talking and talking is a problem. So how do current trainees learn? I'm old, I have gray hair. There was no iPhone, there was no Google, there was no anything when I was there. There was like a bunch of people talking to me. Now trainees learn, they're interactive. They do not want me lecturing to them. Understanding how ironic it is that I'm saying this. They want it to be welcoming, team-based, by repetition. Not say it once and just assume, because I am the professor, that they're going to remember it. You don't learn by lecturing. Again, I understand the irony. And you don't learn by being made to feel stupid or being afraid of asking questions. So ultimately, what should rounds be? Rounds should be efficient. Rounds should be educational. Rounds should be professional. Rounds should be interactive. Round, despite the very serious nature of what we do, rounds should actually be fun. Thank you guys very much.
Any questions for Craig? We call you by your first name now.
Indeed.
Because we are your colleagues. And so maybe you can tell me us a little bit more about this family participation during round, because I noticed that in Europe maybe it's not as popular as in the US. And so what is the role of the family exactly during this round? Do you discuss anything you want to discuss otherwise with the staff only, or how does it work?
Yeah, so first I'll start out, but we have 24/7. There's no such thing as visiting hours. There is, the family's there 24/7. We have beds for the family to sleep in if they want to. They never leave. They're part of family care. They're part of patient care. They decrease delirium and the such. So when it's time to round at the family's bedside, they come out and join us. So we come by, and the family just stands, and we ask them if they want to join. About 10% of people will say no. I don't understand what you're saying. You guys go blah, blah, blah. It's all a different language. I don't want to hear you. Okay. About 90% of people do. And they hear the exact same presentation that you do now. We don't dumb it down for them. We don't English it for them or change it to Dutch or whatever language you want to speak. We speak in actual medical speak. We do the exact same thing, and the only time they actually interrupt is if somebody's giving a history and they say something wrong. Then we actually empower them to actually do it. They hear everything that we have to say, and then what do? Once we're done, I turn to my left or right and I talk to them and I say, okay, now in English. And I actually translate what we just said in doctor speak into English so they understand what we have to say. And I don't have to meet with them later because they've heard, but there's not a question, are they missing something? Is there a secret? The truth is, they know every single thing that we've had to say. They hear the plan. They feel empowered. They feel it's such much of the problem is the lack of autonomy and lack of control, and all of a sudden they feel like they're part of the team, and it makes such a fundamental difference. And they will thank you and they'll say, oh my God, I can do this, and then they'll really be able to explain to the other ones, and they'll call their loved ones and put them on speakerphone, and then there's nothing that I'm saying that's secret. Like, I'm not saying something secret to them. And then people wonder, can you joke on rounds? Actually, the answer is, yeah. Because families actually get that we're human beings. You might not think that, because at the beginning, everybody's resistant, like, oh my God, I can't joke on rounds, I have to be so serious because there's like life and death going on. And in truth, they actually recognize that we're people, they appreciate that we're people, they'll start joking with us. And they'll be like, oh, the so-and-such in the bed, they would love that. They did this for 40 years and they would actually love that. And they're just another team member, but they can actually now be mentally empowered, and it really makes a difference towards them and their whole families.
Thank you very much. There's a question in the back. The microphone will be handed.
Hello, hi. I'm just wondering whether there is a specific format of rounds. Like usually for my country, the medical officer or the junior doctor will start presenting first, but I have read models where we have nurses starting the rounds first on the patient, or even the pharmacist. So I was just wondering whether there's a specific format of rounds that you follow. Thank you.
So there is, but I actually think the important thing is that what works for you, as long as you do it in a standardized fashion, works for you. So I was doing this in a workshop last year with Jean-Louis, and I just kind of assumed that we ran rounds the same way. And it turns out we run rounds entirely differently, but it doesn't matter because we do it in a standardized fashion. He does it in a problem-based system. We do it in an organ-based system. There are some places that the nurses present the patients. There are some places that the residents or APPs present the patients. And it doesn't actually matter as long as you do it the same way each time, and everybody is engaged in the team, and everybody feels that they can speak up. And at the end, you make sure that you look at everybody in the team and say, any questions? Everybody got this? Any concerns? And as long as everybody can voice their concerns and voice where they want to be, because a lot of times you'll say the plan for the day and the nurse wouldn't have said anything if they're not presenting. And they'll be like, I'm really concerned about this. And you're like, I wouldn't have known that had you not said it. So everybody needs to be able to speak up. But then the actual thing that works in your culture is what works in your culture. And there's no one best way of doing it.
Thank you very much, Greg, for your valuable insights. Thank you. So we move on to the next speaker, and that's Mervyn Singer from the University Colleges of London in the UK, and he will learn us how to learn our co-workers at the bedside.
Oops, sorry, going ahead too quick. Hello everyone, hi, good afternoon. Lovely to follow Craig, so I'll try and be funny. Actually, and this talk actually, it's all right, my views on learning and teaching, but at the same time also I'm going to make a plea to you guys in the audience. Okay. Yeah, we're all doing it now, aren't we? But we get a lot from a computer, 100%, but it only gives part of the answer. And increasingly I'm having to beg my trainees to say, the patient's over there. And they look up from the computer and go, huh? The patient's over there. Huh? So I drag them screaming to the patient. The computer doesn't necessarily tell all. Does the patient look ill? That's my best sign of a sick patient. You walk to the bedside and you don't have to clock the colour or the blood pressure or the respiratory. It's just, God, they look ill. And that dictates how quickly you react, or if you've got time to crack a few jokes. And you pick up lots of other things, the colour, are they bleeding, petechiae, abdominal distension, etc., which you don't necessarily get immediately off a computer chart. It might be documented somewhere by a nurse in the middle of the nursing records, but do we go through all of these records religiously? I would argue probably not. And again, seeing if the ventilator's synchronizing well or not. Do they look in pain, grimacing, looking at their eyes? Is there a glint in their eye or is it dull? And I'll come back to physiology later, but the only way we actually understand physiology is by doing it at the bedside, not from behind a computer terminal. And listening to the patient, if they're able to speak, changes in their voice, what's their opinion about things, likewise their relatives and the bedside nurse, because they may pick up things that, again, aren't there. And it's all a learning experience. It adds to that rounded picture. Oh, it's working. It wasn't working. You remember Tommy? It's a certain generation. The Who? Yeah, there's a couple of hands. For those that don't know, go to Spotify, re-educate yourself. This is a learning experience. But this is the film of the record from The Who. And that's what the patient wants. See me, feel me, touch me, heal me. The patient's begging. And that's not a patient in the bed, but his mum and a pinball machine that's not working. Yeah, we don't necessarily want the patient to be crowded, but we want people to participate. Examine the patient, see them, feel them, touch them, heal them. This is 70 years old. This was filmed outside the university where I work now. But this is a style of teaching.
Morning, gentlemen. Good morning, sir. Not late, I hope. Not at all, sir.
1954.
You just lie still, old fellow. I'm just going to discuss your case with these young doctors here. Take his pajamas off, sister. You, examine his abdomen. Take that grubby fist away. The first rule of diagnosis, gentlemen, eyes first and most, hands next and least, and tongue not at all. Look! Have you looked? Yes, sir. See anything? No, sir. Very good, carry on. Gently, man, gently, you're not making bread. Don't forget, to be a successful surgeon, you'll need the eye of a hawk, the heart of a lion, and the hands of a lady. You found it? Yes, sir. Well, what is it? A lump. Well, what do you make of it? Is it kidney? Is it spleen? Is it liver? Is it dangerous? No, don't worry, my good man. You won't understand our medical talk. You, what are we going to do about it? Cut it out, man. Cut it out. And where shall we make the incision? Nothing like large enough. Keyhole surgery. Damnable. Couldn't see anything. Like this. Now, don't worry. This has nothing whatever to do with you. Now, you. When we've cut through the skin, what's the first substance we shall find? Subcutaneous fat, sir. Quite right. And then we come across the surgeon's worst enemy, which is what? Speak up, man! Blood, you numbskull! You cut a patient, he bleeds until the processes of nature form a clot and stop it. This interval is known scientifically as the bleeding time. You, what's the bleeding time? 10 past 10, sir.
So, perhaps not quite the way we embrace people nowadays to teach, but I'm sure they'll remember, won't they? You know, they've seen, they've touched, they've felt, they've listened, etc. And that's more than sitting in a room and being fed passively. There's interaction. So, on the left, the patient had 2 kidneys, we removed one. How many does he now have? Anyone? And even medical students sometimes have to repeat a year. And junior doctors and sometimes consultants. And on the right, what would help Mrs. Johnson to breathe easier? Less cigarettes, lung lavage inhalers. Eye contact would be a good start. And one thing I hate, I don't know, Craig didn't mention it on his round, but when all the doctors and nurses get in a huddle at the end of the bed and ignore the patient. And especially if they're awake and they're trying to listen, they're talking about me. What are they talking about? So it's a learning experience by engaging with the patient and also listening to them, how they're feeling. There are 2 types of ward round. I'll steal some of Craig's thunder earlier. But yeah, there's the business ward round. And this is what I do anyway. Right at the beginning of the day when I come on, you get the handover from the night shift and then a quick walk around the patients. Bang, 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 bang. You can do 10 patients in 15 minutes, basically just looking at them from the end of the bed. Do they look bad? Are they getting up or worse or better? Is the nurse worried? Is there some worrisome physiology or blood result you need to look at urgently? Is the patient really worried about something? They may be complaining of really bad pain, for example. To basically say, right, what things then need to be organised? Yes, we need a CT scan or an echo or whatever. Get those organised early. If you wait until you ask for them in the afternoon, they're not done until the following day. And obviously, can this patient be discharged to the ward? But there are the business learning ward rounds, which are more leisurely, more detailed. So what I do is the junior docs, again, as a learning experience, go and see the patient, examine them, and then come up with a plan. which they then, on the more formal ward round, present to me, and I may agree with the plan, say, yep, that's fine, or I might say, well, what about this? Have you considered that? Is that the best way of doing it? So it's the chance to have a discussion about their suggested management regimen and yours. You can perhaps bring in the literature to actually, make that more a fruitful discussion. So you've got time, and you can be interactive with them over the patient discussing a particular case or an interesting abnormality. Right, we've got this really weird sodium or, blood pressure or whatever. Right, what's the reason? What are we going to do about it? And it's a good way of demonstrating physiology. A dynamic test, a straight leg raise, playing with the ventilator and seeing how the tidal volume changes when you change the PEEP, for example. And as I mentioned, talking about management controversies. There's many shades of grey, but sometimes there's a good way and a bad way of doing things. And again, that's the learning experience. And my big plea, physiology. We're losing the art of physiology. So my big plea to you guys, because I'm seeing it more and more. People are stuck behind a computer. They know bugger all physiology. And this is in the UK, and from what I've heard, other countries are suffering too. And so what will happen if the next generation don't know anything, then that skill will be lost forever. And you can get such a huge amount of information, understanding physiology, doing dynamic challenges, understanding biochemistry. If we lose those skills, I think we as a medical profession are in big trouble. I think the patient will suffer too. So again, learning about the ventilator. The best way to learn about ventilators is not from a book, it's sitting and playing. Hemodynamic monitoring, and then obviously teaching. Yes, you've got simulation training, which is great, dummies, etc. But the real thing is where you really learn on, whether it's putting in lines or drains or catheters, lumbar punctures, learning ultrasound, echo, recruitment maneuvers. All of these things are learning experiences, and so encourage people, rather than just sat at the computer or drinking a coffee, watch your colleagues do it, or even if you're not actively doing it yourself, see what's being done, and also see when things go wrong, because in life, things do go wrong, and it's knowing how to react. You're doing a tracheostomy, per trachea, and they start bleeding. How are you going to react? Because they will happen, even with the best will in the world and the greatest care in the world, they sometimes bleed. So it's good to have seen how other people deal with that acute problem. And finally, for all those who say ventilators are science, I'm going to say, yeah, yes, it is, but a lot of the time you do the complete opposite of what you think is right, and that's better. So there's a bit of art as well. But the only way of learning is playing. Doing it at night is a great time when hopefully things are quieter, and you just play, do one thing at a time and just see the impact of that one change, and then it's cookery. You can follow a recipe, but at the end of the day, the cake will turn out differently each time, so you want to perhaps add a bit more of this or take away a bit of that or whatever. I think that's the art of ventilation. So in summary, computers are great, but please, we mustn't lose our clinical skills, our physiology awareness before we lose them forever. Thank you very much indeed.
Wonderful. Thank you, Merv. Do we have questions?
Maybe I can ask one, Mervyn. You showed how you can do clinical rounds in a very bad way, maybe old-fashioned way. But I also hear sometimes that during handovers or clinical rounds in some hospitals, there are restrictions not to ask any questions to the junior doctors, or because it can be felt as offensive. What is your opinion about that? Because I think for some teaching, there should be some kind of interaction. Yeah. What is your opinion?
I cry when I hear things like that. I'll give you a quick story. One of my colleagues who's very, very good and into simulation, she was telling me she did like CPR simulation, and she got asked for feedback afterwards, and a couple of the trainees complained that they didn't like doing it. They felt stressed doing it in front of other people. And she gently pointed out, well, actually, when there's a cardiac arrest in real life, you're going to have to be doing it in front of other people and leading it potentially. You know, so if you can't learn now. So, you know, so I think, dare I say it, we're a little bit too, we're bending, you know, whether it's political correctness or a sign of the times, but, you know, you need a bit of stress in your lives because then you react better when you are stressed. And so to completely insulate people, I think is equally dangerous, harmful, deleterious. It doesn't help them. And you saw it in COVID. You know, in my experience, the people who reacted were those who are used to doing it. So the intensivists, because we're used to dealing with stress. And the people who couldn't deal with COVID, certainly in the UK, were the government ministers. You know, because they were, you know, they're not used to dealing with stress. And if you look, you know, medics, paramedics, the army, they're brought up dealing with things. So we've got to learn not just playing with physiology, but I think your point, I think I'll add to it, you know, learning how to cope with stress. Important.
There's more question.
Oh, please.
Yeah. Thanks for the great talk. I have one question. What's the best way to get your residents to or to reignite their love of biochemistry and physiology in the ICU?
Yeah, my technique is friendly abuse. You know, because if you scream and shout at people and make them scared, they go, ugh. But, you know, I'd say it with a smile, but go, God, you're a moron. You know, and but I do it to everybody so nobody feels they're being picked on. Yeah, you know, so you ask them a question, you go, do you, you know, and it's just, you know, you put on the act of like falling over or collapsing in a heap. But, you know, but people, you know, that was the way I was taught in an era where it was a bit more abusive. And, yeah, I'm not saying we should go back to that, but you learnt. You know, when that was humiliation and you learnt by humiliation when you screwed up. But now, you know, if somebody jokingly tells you, God, you're a moron, or, oh, you did, you know, then you do remember it. And so at touch wood, in X number of years, I've never had a complaint. So do it with a smile and you can abuse.
Craig, can the microphone
I'm going to be abused now by Professor Coopersmith.
Yes, indeed, actually. So understand that this also varies between cultures. If I did that, it would be so rapid before I would be seeing with the associate dean of students, and quite possibly lose students and quite possibly lose my job. So I'm not suggesting...
You can come and work in the UK, Craig.
Well, you can't, right? Because everybody's... I'm not suggesting that that's wrong, but I will suggest that might differ between cultures. And I think that's important to state.
Yeah, I know, I agree. I think Europe, Arthur, do you abuse your students in a nice way? You know what I mean.
No, sometimes you try to challenge them.
Yeah.
You ask what was the sodium concentration in normal saline or something, and they have no clue. And they prescribe maybe 200 liters already to the patients. You can ask them and say, is it safe to do that without knowledge of what you are doing? And they will never forget. But it's maybe this kind of... But you have to be careful. That was my question also. But can you do it any longer in this time? Because it's...
Well, I do, and maybe it's because they think, oh, he's an old dinosaur, just put up with him. But, you know, I think it's the way you do it, and if you offend people, then clearly, you know, that's bad.
Maybe last question. How do you deal with, you know, you're talking a lot about experiential learning, I think, especially at the bedside, but then we're also struggling with information overload. And I think also now kind of more capability to have information at your fingertips. So maybe when we were training, you were expected to memorize much more, both about the literature as well as pathways. And do you see that changing, or you know, what is the balance there?
Yeah, no, great question, Vinny. I'll actually cite, there was one of the founding fathers of critical care was a guy called Bill Sibbald, who's Canadian. A great guy, and he was, I think, a surgeon by training, and he had a sort of surgical mentality. You know, he didn't stand fools kindly, so if you were an idiot, he'd let you know. But I remember him telling me once that he said, the crucial thing about intensive care is doing the basics well. And I think we can get a bit too carried away with the minutiae and forget the basics. And, you know, Craig made the point in his last talk about, you know, you just want to make sure, is the antibiotic crossed off, or is it time to take out a catheter? Don't agree with him on DVT prophylaxis. That's another talk later this week. But but I think it's doing the basics well. And I think sometimes, I think your point is very well made. There is information overload, and sometimes it's seeing the wood from the trees and just looking back and doing the right thing, the basics right, and then you can do the extra bits on top.
Excellent.
Thank you very much, Mervyn. So let's move on to the next speaker. That's Mauro Oddo from Lausanne in Switzerland, and we'll discuss the topic how to develop research in the ICU.
Thank you. Thank you for the introduction. It's very nice to be here in this working together session. So I'm going to discuss about how to develop clinical research in the ICU. I don't have any disclosures for this presentation. Now, let me just introduce a brief summary on the potential approaches to clinical research. And you see here a summarized view. And depending on what you want to do, this is how you want to build the clinical research team. So you need to think about the development in data, big data, data science, artificial intelligence. That's where we started this morning. Cohort studies or interventional trials. So when you want to approach this, you have to have this in mind. And if you start with interventional trials, you know that this has become more complex, and you want to turn to more complexified design. So when you want to build up this team, you need to have this in mind to identify the people and the way you want to approach clinical research. I think it's also important to not only to think about the, let's say, the first phase of research, how you want to include what you want to do, but also think about long term, and especially if you want to have long-term outcomes. This is very important when you build up your team, to have not only people who can help you in the study design, or in better treat the heterogeneity effect of having the patients involved, but also these important aspects of long-term outcomes. I think this is an aspect that has developed a lot over the last years. So data-driven clinical research is becoming really an important aspect of ICU research. So the very first thing is how you collect patient data, making sure that the quality of the data you collect is well done, and then you can transfer these good quality data from the electronic health record and use this amount of data to get information. And I think that this aspect is very important, and with the development of electronic health record, of bioinformatics, this aspect is very important. And you can even go further on, and there has been already quite a lot of talks today about the use of data, how to understand data, and going further into statistical analysis such as machine learning to capture what you have in terms of patients and distinguish either to prediction or to better phenotyping the disease. So this is, I think, a picture on when you start building a research team and you introduce clinical research, starts and have a good data, good patient data, good quality data, and then how to process this data to build up registry and to have enough information, complete patient data information, to then get these information out and have data-driven research. This is the first start. And the second thing is we have listened about the working together, and I think that the organization of clinical research is very important in terms of building and integrating clinical research at the bedside. And this goes a lot with the relationship between research and education and also professional development. And I just want to identify a few words. In terms of development of a research program, you need to have leadership, but you also need to include the clinical team, provide opportunities for advancement of the staff, and really have research among topics in the rounds, and sort of introducing the culture of clinical research. And as I've shown before, patient data collection, the quality of data, looking at the diagnostics that are introduced, simple but very efficient things that is really necessary. And I think that the education comes to, again, the clinical involvement, and really to provide this culture and create an environment that is putting a relationship between what you do at the bedside in clinical rounds, teaching, and then to have this flow between the clinical, the education, and the research, and altogether this mentorship that is needed to increase the attractivity of clinical research. And what I don't know in your centers, but there is a feeling of change also. And it's not so easy to attract young clinical ICU doctors to engage themselves in doing clinical research. And still, I think that it's very important to have these culture and really to provide an orientation which is clinician scientist. And you can do it by implementing MD PhD programs. I give you an example. In Switzerland, the MD PhD program is currently at risk because there is less financing. So it's not so easy to think about in the future. And what I've currently said last year is that if we are going to complexify clinical research even further, talking, for example, about ethical committees, which obviously are very important, but the regulations of research is becoming so complex that in the end, in 2030-35, there are not going to be many MDs that are interested in engaging in doing clinical research. And the training is essential, but also we need finances. And these are approximate costs per patient. If you want to run trials, then coming back to interventional trials, you see that, data-driven research, if you want to move to adaptive trial, is not necessarily less costly. So we need funds. Right now, the Swiss government has cut by half the finances that go to the Swiss Personalized Health Network. So there is less money around. I think that this is even true in Switzerland. And I think that the training and the culture and the engagement is very important. So we are in need to still maintain clinical research, because this is what is really driving further the therapy and the impact to patient care. And so I want to finish with 2 slides. And very often we think about what is the performance in terms of clinical research, and we think about impact factor, we think about the number of publications, but I think that also very important in the context of a future where finances are in difficulties is that the clinical research is the research that has an impact on patient care. And so we need to measure the innovation, what is bringing new approach to patients and what has an impact on patient care and then transfers into societal impact and also economic impact. We definitely are in times where we need to reduce the costs, and also thinking about sustainability, we have to think that research, clinical research generates a lot of impact in terms of wasting, and sustainability is also an issue. As I said, in terms of professional development, the number of new young investigators that come out from your research team is a very important indicator of the quality of your research, as obviously to obtain recognition by your peers, and this will attract finances. So to conclude, this is not something that is available online, is a sort of personal view of what would be needed if you want to build up a research team. Now, every component are very much dependent on what is available centrally at your hospital, what you want to have locally within your team, depending on the areas or topic that you want to explore. But I really think that the leadership is essential. And the leadership is supervision, but it's also mentorship and driving. And driving the junior researchers is very important. And it's very important to drive these at the bedside. So to really make people involved, I think another very important aspect is to have clinicians from the nursing, physiotherapy, and MD involved. And that's what I have experienced. You really drive the interest of research by bringing people from the clinical field. And then, as I said, research has become very complex, and if you want to really go through all the regulatory aspect, what I could suggest definitely is to have people within your team that who knows all these regulatory aspects. And then the rest will depend on what you want to do. Definitely, if you want to go into data science, you need to have someone, but this could be available centrally at your centers. So with this, I end this talk, and thank you for your attention.
Questions? So maybe I could ask you, Mauro, a couple times it's come up, maybe drying up of a pipeline of young talent and, trainees, I think, who can move this frontier forward. And, then it sounds like, in Switzerland, both because of reduced funding opportunities, but also maybe some generational shifts in, the way that younger trainees are approaching this entire field and then research. What barriers and how should we overcome that? As leaders in this field, what investments do we need to ensure that we make now so that it doesn't become a trickle?
Well, the session is entitled Working Together. So I really think that it's a work team effort, and it starts at the bedside. I really think so. So to really stimulate, looking at what has been discussed by the previous speakers, bringing the importance of the basics of physiology of what we do at the bedside, and stimulate this thinking and get this interest in research. I don't think that we should behave differently. It's just that I think, need to put maybe a higher engagement. I'm also getting old. I probably think that 20 years ago, these engagements was maybe not so necessary. People would come and say, oh, I want to train in the ICU and I want to be like you. And then maybe now there are people saying, I don't want to be like you. Because and there is a development of part-time job, there is a change, and this is just an objective assessment that is nothing bad or good. It's just the reality. So I think that this engagement, bringing this culture, bringing this really to have this mentorship effect, and I think that this starts from here, and not, for example, doing journal clubs and things like that. I really think that is an engagement at the bedside to attract people, because I think that this attractivity has a little bit reduced over time due to many aspects.
Okay, thank you very much for your contribution, Mauro. We move on to, yes, please. We move on to the last speaker, that's Sara Crager from Los Angeles, USA. And we are happy to hear about the expectations from the new generation. Wow.
I didn't choose this topic, by the way. It was assigned to me, so I apologize to my generation if I get it wrong. So, inevitably, my generation is defined by COVID. We didn't choose it that way, we don't like it that way, but it is simply the case. And it's going to frame the way that we see medicine probably for the rest of our careers. I think in the same way, a lot of ways, that the HIV/AIDS epidemic framed the way of thinking for the generation of physicians that was practicing in the 1980s and 90s. Now, I don't have great perspective on that because at that time I was in grade school and much more interested in my Halloween costume. I went with a Ninja Turtle that year. But COVID has framed the way that we think about medicine and probably about life. Now, I was part of a very specific cohort within this generation because I didn't train during COVID. I was part of the cohort that trained in the second half of the 2010s. And if I were to characterize that cohort of people, it would be like this: well-trained and unprepared. So I finished fellowship in July of 2017, and I really had amazing training. I was at Stanford, I had fantastic attendings. It was wonderful. One of the major defining characteristics of this group of people was guidelines. A key part of our training was actually focusing on implementation of guidelines in the ICU. So these were two of the biggest papers to ever come out in modern US history, modern everywhere history: guidelines, ARDS, and sepsis. My entire ICU practice in so many ways was based around these two sets of guidelines. We embraced them. And not just that, we had to memorize them when we talked about them a lot on rounds. We really believed that the best way to deliver good care was strict adherence to these guidelines. So graduated fellowship, everything was basically going okay. As of July 2020, I was at my first academic job. I had, gotten my first grant proposal rejected. I was being good junior faculty and just starting to find my feet as an attending. Somebody would walk into the ICU and be like, "Where's the attending?" And I would look around and be like, "Oh yeah, that's me." I was finally sort of getting there. I think we all were. And then we hit March of 2020, and the rug was pulled out from under us. Or, as this morning one of the speakers talked about, the comfortable couch of evidence-based medicine, we got kicked off the couch. Fast forward to Christmas of 2020. I found myself in the ICU that I was helping out in. It was a non-academic hospital in a place nobody's ever heard of called Lancaster, California. And in this ICU, I had almost 50 patients. I was taking care of them by myself. I had a team of nurses and respiratory therapists, and everybody was dying. And I was doing my best. I was doing what I was trained to do. I was following the guidelines. I was going with the algorithms. The problem was, I would get to the arrow, then the next arrow, and then I would fall right off the page because there was no next arrow. I had lots of these moments. I did all the things. I did all of them right. I did them as I was trained to do. Now what? And what my training had not prepared me for was to figure out what to do with a bunch of people on my team looking at me being like, "Well, now, at this moment." It really made my generation rethink about evidence-based medicine. When I trained, this was like, this is what you did. It was unquestioning that the best, only way to take care of patients well at the bedside was to strictly follow the evidence-based medicine guidelines. But then we ran up against COVID, and we did that, and it wasn't working. And I think we really need to acknowledge the limitations of that. Specifically, we need to think carefully about the limitations of very, very strict one-size-fits-all guidelines, and when that can be helpful, but when that can be harmful. and refocus on personalized medicine. We need to be allowed to take care of the patient in front of us. And so much of the time, when I was trying to figure out what do I do with this patient in front of me, I'm following the protocol. The protocol's not working, and I would try something new. Everybody would say, but that's not evidence-based. Where's your evidence for doing that? And I would be like, well, the patient's dying. I got to do something. But it's not evidence-based. You can't do that. We need to be allowed to take care of the patient in front of us. And it's obvious that it matters whether the patient I just intubated is 80 and has pulmonary hypertension, pneumonia, or whether they're 24 and have the flu. It matters. But it also matters who the operator is. Operator dependence is a thing. And whether the person caring for that patient I just intubated is an intern who graduated medical school last week or is an intensivist with 10 years of experience should matter. And I think that following the guidelines strictly probably makes a lot more sense for that intern who graduated medical school last week. That provider with the experience of 10 years, they may do better for the patient in front of them, potentially by not. So what I actually think we should be doing is not so much saying strict adherence to guidelines versus not, but is there an alternative for us intensivists? And I think the alternative is expertise. Because once we realized that the guidelines and the evidence, they weren't going to get us through COVID. They weren't going to get us through every situation. What I think we need to be doing for future, for my generation, and more importantly, training the future generations, is expertise. Now, what do I mean by expertise? Because when I say that, it sounds really nice, right? It sounds inspiring, but like kind of squishy, right? Like, what do I actually mean by that? Turns out that there's actually a moderately robust science of expertise that I think can inform us how to train people in future and how to improve our own practice to do better for the patient in front of us. And the first thing we know is that, overwhelmingly, the evidence suggests that experts aren't born, they're made. That we can't use the excuse of, I'm just not that talented, I'm not just that naturally gifted at ventilators. That's not an excuse. You can turn people into experts. Now, a defining characteristic of experts is that they use qualitatively different cognitive strategies. It's not just that they know more, they know it differently. Their brains actually look different. If you ask an expert versus a novice in a project, if you ask them a problem, their brains look different when they're solving it. Because at the end of the day, expertise is not so much about what you know, it's about how you organize your thinking and how you organize that knowledge. And the essence of expertise, it turns out, is all about what we call mental models, particular ways of organized thinking. And the more quality and quantity mental models you possess, the more of an expert you are. And what's really interesting is that you can actually see this happening in real time. You can watch the formation of expert mental models as somebody's learning. So one of the earliest studies of expertise was a study they did where they were trying to teach somebody to memorize long strings of numbers. Why you'd want to do this, I don't know, but that's what they decided to do. So they did the guy, normal guy, college student. They were like, okay, we want you to learn to memorize strings of numbers. He, as many of us, started with maybe 7 digits in working memory. Then he started working on it. He started learning. And slowly he made incremental progress. He could memorize 10, 12, 15, as you would expect. Then, all of a sudden, something interesting happened. He went from being able to memorize maybe strings of 15 numbers to 45. Then he progressed on to serially memorize more and more strings until eventually he could memorize strings of 80 numbers after hearing him once. Now, that's not that useful of a skill if you ask me, but that's not the important part. The important part is right there. What happened right there? That is the essence of expertise. Because what happened right there, that is acquisition of a new mental model. And you see this pattern in learning of expertise. In everything from music to chess to medicine, it recurs over and over again. But at least as importantly for our purposes is teaching expertise. Because it's very well for me to say that we should be trying to make ourselves experts if we can't systematically teach them and create them. How do we do that? Turns out you can. So they went on with this study then to take the first guy who could now memorize these strings of 80 numbers, be like, you teach this other guy how to do it. And when they had him teach the next person how to do it, that mental leap, it came faster. We can teach expertise. How do we do it? We deconstruct and reconstruct our mental models. That is how we teach and pass on expertise, and it can be done, but we don't tend to do it in medicine. This is the way that I was taught acid-base. Probably the way most of you were taught acid-base. This right here, this is not a mental model. This is a mental model. And this is how I like to start teaching acid-base to my residents. But we need to take this passing on of mental models beyond just pathophysiology. We need to take it to clinical problem solving. When I was a resident and a fellow, every time we'd have a lecture about problem solving, I'd be like, I'm going to skip that one. That's going to be useless. Because we make it into this soft topic where we give people very vague things that aren't really that helpful. But if you watch an expert clinician, they do have clear mental models of problem solving. So instead of being like, yep, do some good hard thinking and cross your fingers and hope you're feeling smart today, work with people on giving them a mental model to use to solve problems. So for example, when I'm trying to work through a sick patient, a sick resuscitation, this is the mental model I like to talk about. Iterative hypothesis testing. Gather some data, interpret your data, revise your hypothesis, adjust your management, gather some more data, re-revise your hypothesis, and off you go. This is something I can do aloud at the bedside, get my residents to do with me, and have them practice. But in order to do this, in order to teach a generation of experts, we need to become better teachers. It is much easier to give somebody a bunch of papers to read than to deconstruct and reconstruct mental models, and then to teach them. Because learning requires attention. My generation has notoriously short attention spans, apologies. But at the same time, I mean, here's the thing. If people find a movie boring, nobody blames the audience, right? That's not a thing. They're not like, oh, it was a bad audience, not that it was a bad movie. Now, that's not to say that learning should be easy. It's not. Learning is very, very difficult. What I am saying is that if you think about the amount of time and energy we're asking our trainees to invest in the hard work of learning, we should be investing an equally amount of time and hard work in teaching. And we don't really do that. I mean, think about the last time you spent hundreds and hundreds of hours writing a grant. We do that all the time as academic faculty. Who actually can spend, or is being allowed by their chair to spend, hundreds and hundreds of hours writing one lecture? Getting just that perfect analogy, making it accessible and entertaining and deconstructing their mental models, that's not what that's not our priority as academics. It's not what we're prioritizing doing. It's not what we do. But I think it should be. I think we should be investing that kind of time because that's what it's going to take. We're also, I think, going to need to invest the time in restructuring how we teach people longitudinally. So when I was a resident, at the beginning of intern year, I was given a book and I was said, all right, start on page 1, you're going to read 1 chapter a week until page 2000 something, and then you shall know emergency medicine, the end. If only it worked that way. Learning isn't linear. In the same way that we wouldn't draw a picture like this, where we fill in every single detail in every quadrant and finally finish the picture, that's not how we actually draw a picture, and it's not how we learn either. Learning, like art, happens in layers. And so what you need to do is not say, I'm going to read a chapter from beginning to end, then I will know the topic. You need to layer on ideas, and as I'm learning as an attending, often the picture is never done. You keep filling in details probably your entire career. What this means, though, is that we need to restructure didactics. This idea that we're going to have cardiology month, where we learn everything we're going to need to know about cardiology this 1 month and then we're good, that's not really how it works. We need to design longitudinal teaching curriculums where we can introduce a concept, layer it on, teach it in different contexts, and interleave it with other ideas that we teach the same way. We also need to be able to bring these ideas to our students at a good learning moment for them, which may or may not be a convenient teaching moment for us. But if I have a patient or I have a student who just saw a patient code because they had pulmonary hypertension and they got 3 liters of fluid, they are much, much more likely to learn about that patient if they can watch my talk on right ventricular failure that night when they come home from shift, rather than waiting for 6 months for somebody to actually give that talk in conference. Now, part of what that means is taking advantage of online content. Now, it is just the case that online teaching and learning is going to be a part of the universe for our students, for future trainees, forever. It is the modality that we use, we want to use, and we are going to continue using. In addition to the fact that it allows trainees to access the content they want when they want it, it allows us to disseminate that content beyond just a single ivory tower institution, to get the best content out there. But everybody's always like, but oh no, unregulated content, this is not good. There's no peer review, and there is no peer review online. But what I would say is that a trainee coming to me with a sort of half-baked idea they got off a podcast is really not that much different than a trainee coming to me after having read the conclusion sentence of the abstract of a poorly done research study. In all areas, we simply need to learn to be good, sophisticated consumers of all medical media, whether that media is in a podcast or a New England Journal article. And I think as an online community of teachers and learners, if we do the same thing that we try to do at academic institutions and in peer review, which is we encourage discourse, scrutiny, and debate, that is how we regulate an intellectual environment. And now that there's so many more actors and teachers and learners on this online clinical environment, I think that we can do that. So I don't know the black box of what's going to be happening in July of 2037, but we know we don't know. There could be another pandemic. I'm not sure what it's going to be, but I think that in order to best prepare ourselves and our trainees, we need to start thinking about the evidence, the guidelines, and the algorithms as a place to start, not a place to end. It doesn't replace your critical thinking, and it doesn't say, you need to follow these even if you're an expert. Instead of relying solely on the guidelines, we need to think instead about cultivating expertise. And ourselves and our trainees cultivating the ability to take the evidence and integrate it with our understanding of pathophysiology, our ability to do clinical problem solving, because this is how, I think, we address the challenge of we don't know what comes next. We deliberately and systematically create experts who will be able to deal with it, whatever it is. Thank you.
Craig. Looks like it's coming to you.
If you ask half the world, if you ask the world, are you, okay. If you ask the world, are you an above average driver? 90% of people or 95% of people will tell you they're an above average driver, even though 45% of them will be wrong. If you ask everybody at this meeting or anyplace else, are you an above average clinician? Just about everybody is going to tell you that they're above average. How do you deal in your expertise model, which parenthetically I entirely agree with the fact that about half the people are going to misperceive that they have tremendous expertise, that they can give tremendous personalized care, and in fact, they're really bad, and when you're getting people in your ivory tower from somebody else who perceives that they're an expert, you're like, oh my God, they're terrible, and yet they perceive they're a really good clinician, just like they perceive they're a really good driver. Parenthetically, I'm a bad driver.
And you recognize it, which is actually the important part. And this is the hard part. I mean, this is the idea behind really, in a lot of ways, guideline-based care. It's the idea that, on average, we will do better for our patients if we sort of say, almost lowest common denominator here, like people, one, either are bad at what they do, two, they are worse than they think at what they do, and they don't know their own limits and abilities, and that is absolutely true. And so the answer that we've come up with collectively is to say, we're going to give you some guidelines and you should follow them. And we are never going to go around the fact that people have really poor perceptions of their own expertise. They're going to think they're experts and they're not. That being said, I don't think that we can ever get beyond the fact that that is going to be the case. But what I do think we can do is do training better. Because we're not really training people to be experts. We're having them read books. We are having them read papers. We are having them memorize things. But we're not training them actually to be experts, not explicitly and systematically. So I can't control the fact that people will always believe that they're a above average driver or teacher or intensivist. But I can control my training programs. And I think that we also can kind of say, if you are at a certain level, if you have not trained in fellowship in X, Y, and Z, you should follow the guidelines. If you have trained in fellowship in X, Y, and Z, that doesn't mean that you're going to know yourself well enough to be like, well, I did that fellowship, but like I didn't really learn that much. But even so, nothing's foolproof. So I think if we can say, okay, if you are at or below a certain level, you'll probably do better by following the guidelines. Just do it. Like when I'm in the ED and I have a pediatric orthopedic patient, I'm like, guidelines, I'm going to just read them off and do what they say because I don't know what I'm doing. In the ICU, I think if one, we can direct our fellowship training to training people to be experts, and then two, more clearly define who should be following these guidelines and when not, that is probably the way to get around this, because I don't think we're going to beat the human psychology of thinking we're better than 50% of the other people.
Thank you. Mervyn Singer, please.
Thank you. Thank you very much. Lovely talk. Thank you. Enjoyed it. Just want to come back on guidelines, because
Yes.
I rail against guidelines. But
And I was nervous saying that with you sitting in there, because I was like,
no. But the actual word guideline is not a mandate or a protocol, and we've unfortunately lost sight of that distinction. And I just wanted to quote one of the godfathers of clinical, evidence-based medicine, a guy called David Sackett. And I can give you a great article he wrote 30 years ago, where he said basically guidelines are for populations, they're not for individuals. You cannot divorce clinical expertise from guidelines without the clinical expertise to say those guidelines don't fit that patient, we're dead. And, I thought, great statement, and, but it's unfortunately been distorted, misquoted, and as you say, follow the guidelines. So,
100%. I mean, I think this is how guidelines should be used. And the problem has become they've been literally institutionalized. So in the US, if I give my patient who meets SIRS criteria and is hypotensive 29.5 cc's of fluid instead of 30, I will get an angry email from an administrator asking me to justify my practice. And I literally have dot phrases that I use being like, in this particular case, because I think everything in moderation, like guidelines can be useful, but the pendulum has swung, especially for my generation of intensivists, that I literally get angry emails from a non-physician who's an administrator of who knows what if I don't follow them literally and precisely. So in a way, for my generation, this is what we need. We need to be reasonable and thoughtful in finding that balance between guidelines, and the guide part of that word seems critical, versus expertise.
you need liberation.
Exactly, that's the one. From ventilators, from guidelines.
Let's conclude this session with this comments. Thank you very much, Sara, again, for your presentation. Thanks to all the speakers and you as audience for being here. Have a wonderful time in Brussels, and there will be another debate continuing this day. See you.